All right, welcome back, and congratulations in that this is the final narrated PowerPoint presentation from Loosening the Grip. This presentation will look at Chapter 14, the final chapter in Loosening the Grip that is appropriately titled Odds and Ends. Again, the narrated presentation is not meant to replace your reading of the chapter, instead to highlight those points that the author identified as being key points in that chapter. So the chapter really is going to be broken down into these following 5 primary concepts. We will make some quick comments about all of these, looking at our role beyond being the counselor, what we do in addition to counseling, looking at actually the area of prevention. Many times people are looking at potentially getting into the field of substance abuse treatment, not recognizing that there is a whole field, a specialization that looks at preventing the use of alcohol and other mood-altering substances. So we'll take a quick look at prevention, take a look at what it's like to be practicing in, quote, the real world. Also an important topic, the topic of ethics. And then lastly, some things that are unique to our field, potentially, which is clinicians who are in their own recovery and how that both enhances and complicates efforts to be a good substance abuse clinician. So one of the things that they talk about in the chapter right up front is the things that we have to do if you're a counselor, if you're a clinician, the things that are required of us beyond being, quote, the counselor. And if you go to work for an agency, these would typically fall into the category of, quote, other duties as assigned. But there's a variety of things that we do besides running groups, conducting individual sessions, conducting assessments, talking to insurance companies, things like that. And those are highlighted here. One of the things that we often have to do, both for our clients but outside of the clinical setting, is to deliver educational activities, is to conduct seminars, to conduct workshops, to inform the public, to inform family members, to inform other professionals about the field of substance abuse treatment. And so some examples of those are listed here. On a public level, you may be involved in your community, presenting to students, to faculty, to probation officers, to law enforcement, to other agency staff. You may also be invited to speak, especially nowadays. There's many more opportunities to speak, not just on radio or TV, but actually through webinars, webcasts, things like that. And then certainly you will also be participating in continuing education, professional education as a participant, but as you develop your skills, you may also at some point become a presenter. You may be conducting in-service training either for the agency staff at which you work, or you may be conducting professional development training for individuals outside or beyond your agency. There's a nice quick summary in the chapter highlighting some of the do's and don'ts if you are in fact in that presenter role. They're both listed here. Probably what I would highlight in particular is do a good job, and I think all of the items in the do column really come down to doing a good job, making the presentation entertaining, appealing, captivating, give the audience and participants time to talk with you, to ask and respond to their questions. And then the flip side, the don'ts, one of the biggest things that I would highlight is that recognizing that when we're presenting as a representative of our profession, then it is not a self sort of serving account. We're not conducting a personal crusade. We're not really using our personal beliefs to bias our presentation. What we're doing is recognizing and acting on behalf of the field as a whole versus carrying out a personal crusade. So take a look at the discussion of the do's and don'ts of conducting presentations as you read through this chapter. When you have the opportunity to present, the couple things in addition that they highlight is that make sure we have talked and you will continue to hear what's called scope of practice. We are prepared and qualified to talk about and to train people on what we do know. We should not be providing training to people outside our area of expertise or area of knowledge. You will develop specialized knowledge and skills. You'll know how to work with potentially certain subgroups or use certain approaches. So certainly share information you have that is specialized and unique that other folks may benefit from. Again, prepare well, invest the time and energy in developing the training, also in maintaining your own understanding and awareness. Don't just wing it. Develop things and then spend the time reviewing it both prior to and then after the session to see what went well, what you need to revise, what you need to tweak. what you need to update, things like that. Again, if you're training people in a what I call a live setting, give folks a chance to both ask questions, make sure we respond to their questions, and allow adequate time for discussion. We always know typically what we want to present, and we think it makes sense to us, but it may not make sense to our audience. And if we don't give them the chance to discuss it and to help wrestle with it and make sense themselves, they may walk away feeling uneducated from the event. We're now going to quickly turn our attention to the discussion of prevention. Again, as highlighted with the opening to this chapter, many folks who are looking at getting into the field are looking at it from a treatment side. This is really a reflection of a couple things. You probably heard the saying, an ounce of prevention is worth a pound of cure, and there is recognition that when we can prevent people from developing a substance use disorder, then our efforts provide more return than if we wait for someone to have a condition that now needs to be treated. And so over the last probably 30 years or so, there's been continuing emphasis on the development of prevention approaches using really a public health model. And prevention can be organized along three different frameworks. There's what's called primary prevention, which is broad-based but looks at individuals who have not yet developed a specific condition, and in our case have not experienced or developed a substance use disorder. So primary prevention is really broad-based to help people from developing a disorder. Secondary prevention, it really is then crossing the line from preventing to now identifying and treating people who have in fact developed the disorder. And then tertiary prevention, by definition, is when somebody has a disorder, has been treated for it, and from a substance use disorder perspective, the illness has reoccurred, they've relapsed, and other settings that again would be a reoccurrence of an illness. So prevention really looks at primary, secondary, and tertiary levels. Most school-based prevention programs are really considered primary prevention. In a similar vein, CSAP, the Federal Center for Substance Abuse Prevention, has come up with terminology that they call prevention efforts can be either adopt what's called the universal approach, they may include selective prevention approaches, or they may be what's classified as indicated prevention. Similar to the earlier discussion in terms of the primary, secondary, tertiary prevention, the universal approach is directed at all people, people who have not yet experienced a condition, and so there's no specific risk factors that are unique to that particular group. Selective prevention is now targeting individuals, but groups of individuals who have been identified typically through research as being at higher risk for developing a problem than other non-high risk individuals. And then the third stage is what's called indicated prevention, which is not group specific, but instead really is individual specific, again targeting those individuals who are identified as being at high risk for developing a specific condition. So similar, but a little bit different perspective on focus of prevention efforts in relationship to the first model that we looked at. In contrast to both the public health model and the CSAP model that we just looked at, which really focus primarily on individuals, either individually, no pun intended, or groups of individuals, there's another approach that's emerging recently that really is focused more upon systems as a whole, environmental approaches to prevention or social approaches to prevention that really don't look at people uniquely as individuals, but instead look at what's happening in the system, what's happening in the ecosystem of the world that puts people at higher risk. And so recognize that a couple models focus more on individuals. More recent trends have focused on collective groups of people, systemic perspectives. Prevention is oftentimes contrasted with the supply reduction approach. Supply reduction is looking at reducing the amount or the availability of substances that people can use when we're talking about drugs or alcohol. So the supply reduction side are things like interdiction and law enforcement and reducing substances on the street, etc. It tends to be more of a law enforcement-based approach. Prevention is looking not at reducing the supply of the substance, but instead reducing the individuals who are interested in consuming or using the substance. So prevention really is contrasted oftentimes with the supply reduction approach by saying, look, if we can reduce the number of people who want to use a substance, then obviously there'll be a concurrent reduction in individuals who are experiencing complications of their use of alcohol and or other mood-altering substances. In general and historically, our current prevention approaches are now focused primarily on adolescents, particularly pre-adolescents. Over the years, we've recognized that middle school, high school, even pre-middle school are targeted ages for addressing young people, for children and adolescents, either prior to or at the early onset of experimentation and use and things like that. As a part of that, and as was highlighted earlier, or referred to earlier, is that so therefore, in addition to targeting this group of people, there's been a whole development of a field where there are specific individuals, personnel who are qualified. They are qualified by virtue of their background, of their education, of their training, and there's also funding. There's programs on a federal level. There's the Center for Substance Abuse Prevention here in the state of Illinois under the Illinois Department of Human Services. There's a division of Family and Community Services, which has a Bureau of Substance Abuse Prevention. So programs, agencies have been created that specifically adopt and implement research and evidence-based practices to help reduce the likelihood that a young person is going to be choosing to use substances, as both increased our understanding of what is effective from a prevention perspective. You're going to see a couple of videos as part of this module that will talk about what we know works. There's a discussion of the DARE program, which was something that many of you may be familiar with, which ultimately was proven to be ineffective or ineffective. But there's recognition that there are certain strategies and approaches that work, and as we develop an understanding of those strategies, then those are the programs that tend to be implemented because we want to do things that have the desired or the intended impact. About some of the challenges with our current prevention approaches, and the first two go hand in hand there, meaning abstinence as a goal rather than a means can help cloud the thinking, because what happens then is people begin to perceive prevention programs that are abstinence oriented less like sort of a public health effort and more like a legal sort of policing enforcement perspective. And so we really have to be cautious about how messaging is done to help people understand that we're really about decision making and about perceived risk, benefits, etc., versus trying to implement kind of a legal policing approach to mandating and to enforcing abstinence. And then also, we've talked a little bit in the chapter previously about the whole controversy between abstinence-only approaches versus harm reduction approaches, i.e., is the goal to, in fact, enforce abstinence completely, or is the goal to simply enforce good practices, which may not include complete abstinence, but instead are risk reduction kinds of approaches. So the chapter does a nice job of, again, discussing and acknowledging some of the challenges. The last thing that the chapter talks about in terms of discussing prevention is a recognition that we have evidence-based and research-based programs that are available. Implementation of those is challenging, is not easy to do, in part because what we found is that in order to be effective, prevention really has to be comprehensive. You have potentially heard the whole saying, it takes a village to raise a child. It takes a community, or it takes a system to really have effective broad-based prevention programs and strategies. And so we know what works. We also know that to implement what works is not easy to do in, quote, the real world. It doesn't mean we don't attempt to do it. It simply means that we acknowledge the challenges and continue our efforts in spite of the fact that we know it's going to be a challenging piece to do. The remainder of the chapter really begins to talk about what I call our professional role, or our professional identity. And so if you haven't thought about this before, it's important to be thinking about this, because if and when you become a substance abuse counselor, you're now a member of a profession. You're now a professional by definition. And so it carries with it both certain expectations and certain obligations. And so they do a nice job in the chapter of identifying these things. One of those is, as a professional, we're expected to share what we know with our colleagues, to work with people in what's called a collegial fashion. We're collaborative versus competitive. Our interest is in advancing our field, advancing our profession, and ultimately we're going to talk a little bit about ethics, but ensuring that everything we do is focused on helping our clients get better. We also then have a responsibility to maintain our own skills, to maintain our own professional understanding, to encourage professional development on the part of other people. And they talk about a variety of ways that we can do that we can both engage and encourage professional development. Sources of information, how we can acquire new skills, either off the job or on the job, now disseminating information, sharing information with other people. Obviously, most people today are familiar with access to information via computer literacy, computer learning efforts, and then reaching across the field, interdisciplinary contacts. And so it's reaching to other addiction professionals, but other professionals that we interact with. It could be medical professionals, it could be psychiatric or psychological professionals, academic, probation, court service, legal, things like that. So there are some expectations that if you haven't thought about, you want to begin to think about as you get ready to move into this role of being, quote, a professional colleague. They also talk quickly about selecting a profession within, or I'm sorry, selecting a position within the profession. And so there's recognition that even as a substance abuse professional, even as a substance abuse counselor, there's a variety of things that we can do. Some of those based upon where we're working, the agency setting, the clientele. If you're working in inpatient, then you have multiple opportunities. If you're working outpatient, there's a little bit fewer opportunities. If you're working with adolescents versus adults, criminal justice, etc. So the variety of what we can do is going to be in large part influenced by where we're working and who the agency works with. They talk about the responsibility of our assessment of ourselves, a professional inventory of who we are, who we want to work with, who we work well with, things like that. And they talk about career advancement. While you may start out as an entry-level clinician, as an entry-level counselor, you may decide that you want to move up. You may want to do other roles, take on other roles, which will be influenced in part, again, by the agency. It'll be influenced in part by our academic preparation, our credentials, our license, things like that. And so we have to be thinking not just about who we are today, but who we hope to be down the road. It is a small field, and so we have to be mindful of the fact that what we say and what we do and how we act is all going to be spread among the field. We're the guardian of our professional reputation, and I would encourage you to be mindful of developing a reputation that speaks well of who you are, that if you're ever looking to change your professional home, that what you're doing at your current job is good enough that it makes other people outside of your current job wanting to hire you, being interested in you. So think not just about today, but think about the future. And their discussion about what it is, comparing what it is and what it's not be in terms of being a professional. There's a couple of slides here that are going to take a look at that. Uh, and I think they're actually self-explanatory. It means identification of ourselves and recognition of ourselves as a profession. It is a constant openness to evaluating how well we're doing what we're doing. Should we be doing more? Should we be doing it differently? Things like that. It isn't the flip side of it about getting so overwhelmed by the people who are coming to us and seeking assistance, seeking help, things like that. We learn how to keep ourselves healthy, and I'm going to talk about that a little bit later in this presentation. So we learn how to set limits on what we do. We recognize that if we spread ourselves too thin, we're not going to be able to do our job well, and we're potentially dangerous not just to ourselves but to other people as well. And there's a discussion, a recognition of the difference between being responsible to our clients, versus being responsible for our clients. And I'm going to just leave you with that question. If you think it through, are you responsible for your clients, or are you responsible to your clients? This is a repeat of that earlier slide, and I don't know why, so I'm going to move forward. You may already know this, but as a profession, professions have some procedure process in which you can either become certified or licensed. In some states, you can be a licensed chemical dependency counselor. In Illinois, you can be certified as a substance or certified alcohol and drug counselor, CADC. The bottom bullet here talks about the Illinois Alcohol and Other Drug Abuse Professional Certification Association, Inc., or IODAPCA. If you haven't heard that term before, you'll begin to hear it now, and through the rest of your training, you continue here. So Illinois, for substance abuse counselors, is a certification state. Whether you're working in Illinois or working elsewhere, if you're entering the profession, you need to obtain appropriate certification and licensure in order to do your job. And so Illinois is a certification state at present time. Other states are a licensure state. So if you leave Illinois, you'd have to find out what the requirements are and what the model is towards allowing people to practice as a substance abuse counselor in that particular state. And then the last couple of pieces to talk about is each profession has expectations for the members of the profession, a code of conduct, or more importantly, a statement of ethics, ethics in terms of how professionals in the field are expected to conduct themselves. And so take a look at this discussion. There is also going to be a nice video in this module that talks in more detail about ethics. And so this is really a brief overview and a prep for the video that you're going to be looking at as a part of this model, as a part of this module as well. Ethics talks about what it is we should do or what we ought to do, i.e. the oughtness of behavior, and at a minimum level, there are at least three aspects to it that we value and we work to ensure that our clients have the right to make their own decisions, i.e. to be self-directed, they're autonomous. This also, similar to physicians, the second one on there, beneficence, i.e. Do no harm, that our role is to do good, and in particular, as a part of that, our role is to ensure that we're not doing any harm to our clients. And so the protection of our clients and the protection of the public from an IDAPCA perspective is one of the most important elements of being a counselor here in Illinois. And then also an awareness of and a valuing of and the support of justice, and really talked about more social justice or fairness, the ability to advocate for all of our clients, to see people for who they are, to see past differences, and to protect the rights of all people. So these are basic sort of understandings of ethics. In their discussion of ethics too, in recent years, there's a couple things, two things actually. You will hear more about confidentiality. Still is stigma attached to having a substance use disorder, and so we worked very hard. We have a long history of ensuring that we protect the privacy or the anonymity of individuals who are receiving services, treatment services for substance use disorder. And they talk about one of the challenges is that with everything becoming electronic, email, texting, internet access, things like that, that we are really challenged today. The field is challenged, and other professions are challenged, the medical profession, about the sharing of information electronically. If you email somebody about a client and you include his or her name in that email, then it's unprotected. And if that email gets forwarded, at some point their confidentiality can be violated. So take a look at this and be mindful of practice about unintentional ways by which we violate our principle of protecting a patient's anonymity or confidentiality is really the legal term for what it is that we're trying to protect. Then the other piece is the old setting of boundaries, roles and relationships, who is responsible for what. We really have a responsibility to ensure that boundaries are defined, established, and maintained, and that's discussed in the chapter as well. They do talk, and I'll go quickly through this, is that ethical concerns come up across all sort of settings in the substance use disorder treatment area. It's not just in the clinic or in clinical settings. So if you're a researcher, if there's violations that occur in the field as a whole, and tensions, ethical tensions that occur in the field in terms of policy and procedures, etc., they also occur in the public policy domain about even issues nowadays. We have obviously a big issue in terms of the legalization, decriminalization, medical marijuana, social marijuana use, etc. So there's ethical concerns that come up across the field, across every level that we have to be sensitive to. As you move in the profession, it's important to recognize up front that it is in fact a demanding profession. Helping people can become overwhelming. And so we have to be really conscious of what's called burnout here. When we are in a constant role of responding to requests for, to demands for, to the need for help, then at some point, if we're not aware of the bottom point here, i.e., taking care of ourselves, the self care, it's really easy to fall into the trap of becoming so overwhelmed that we feel burnt out. So there's a nice discussion of burnout in this chapter. So take a look at that. Because of that burnout, the field itself is really dominated by a high level of clinician turnover. People enter and leave the field or enter jobs and leave that agency and move to another agency because of the demands that are placed upon us. And so in order to manage those it's really important that some of the things we talked about earlier, boundaries, self-care, are things that we are mindful of and that we establish and maintain in order to keep ourselves from becoming caught up in the trap of burnout and clinician turnover, which ultimately leads to decreased outcomes for the clients that we're working with. One of the things that is a little bit unique to our field is that many times individuals who come and become counselors oftentimes come because of their own history of being in recovery themselves, recovering from their own substance use disorder. And there's many, many benefits about being in recovery should you get into the field with that as a part of your background. But there's also some risks and some challenges that come with that. And so they really do a nice job in this chapter. And if you are a recovering individual who's looking at becoming a counselor, I encourage you to continue to be mindful of this and explore in more detail and how it applies to you, because the short story is that so in addition to working in the field, clinicians who are recovering also have to make sure that they continue to attend to and maintain their own recovery. And so there's really kind of dual responsibilities, conflicting interests, and also potentially conflicting roles. If you're in recovery and a member of a 12-step organization, all of a sudden now you may see clients that are now attending 12-step meetings that you're attending, and you're no longer in those meetings. You're not now their counselor. You're another recovering person. So how do you handle that? What do you do when those things come up? Some of the challenges that are highlighted here are the two at the bottom. If you're recovering counselors can sometimes begin to identify and become tied to their job and lose sight of the importance of their own recovery. And so it's really critical that if you're recovering, you continue to be mindful of what I call both sides of the equation. You'll hear sometimes people talk about this as wearing two hats, wearing the professional hat, wearing the recovering hat, and which hat are you wearing at one time. You have to be mindful about both sides of the equation. And the other thing has to do with roles and boundaries is terms of, talking with other members of the fellowship about either your position or the clients that you're working with, or potentially vice versa, talking with people on your job about individuals that you're seeing in self-help meetings. And so, boundaries, awareness, violations are all things that can happen easily that can make it really, really challenging to separate personal recovery from professional identity. So they do a nice job of introducing this in the chapter, and if that background applies to you, I will encourage you to continue to be thinking about it, and to be mindful of it, and to talk it over. Talk it over not only in your fellowship, but as you become a clinician, with your supervisor, with your coworkers, things like that, so that you can help manage both aspects of who you are. One of the challenges which is acknowledged, which we have to acknowledge, is that again, when people enter the field, if they have a history of recovery, or even if they don't, that there are individuals who enter the field who become impaired through their own use of substances while they're actively working in the field. And obviously that becomes a challenge or a problem, really. It's even more than a challenge. It's a problem when you're trying to counsel people when you're experiencing substance use problems of yourself. And it's not unique, or it's not only in our field. If you're impaired and working in any field, it's a potential problem. But when you're counseling people and struggling with your own issues, it can becomes even more challenging. In general, most programs have policies and procedures in place to help identify it, to help address it should it occur. You will see in this module when we're going to post the IODAPCA Code of Ethics that IODAPCA really has expectations about clinicians and impaired clinicians and how to get help, what to do should that come up. So take a look at those as you continue the work in this module. So that really is a quick overview of this chapter. It leads us to, or it leads you to perhaps the questions here. This is the final chapter in Loosening the Grip. It's also the final module. And so as you think about what you've been introduced to, what you've wrestled with, what you've thought about, what you've learned in the course of this course, no pun intended, and you say, hey, I still want to go ahead and become, quote, a professional helper. I want to become a counselor. Two questions that then come to mind. How are you taking care of yourself right now? And how will you take care of yourself if you become a professional helper? If we're not taking care of ourselves now, it's even harder to learn to take care of ourselves should we enter the profession. So think about both of these today, here and now. What are you doing today to take care of yourself? Do you take care of yourself? Is self-care important in your life right now? And as a part of that, if you look to the future and you become a professional helper, what will you do to continue to take care of yourself at that point?